Thank you, Melinda, for the kind introduction, and thank you very much to everybody who's live here in the NUHS Tower Block Auditorium, and many people who are joining virtually. And indeed, it's a pleasure and honor to be able to present some information every year to all of our patients. And it really is a pleasure to learn that as patients you're coming together and form a group, and as probably Daryl and others will allude to later, it's absolutely vital that patients come together and make up this advocacy group, as the treatments that emerge for myeloma are getting increasingly more complex, so that we can navigate through this complex pathway together as physicians, patients, carers, physiotherapists, all the allied medical health staff, etc. Today I would like to concentrate on a couple of quite different topics. As patients always, you come and ask us physicians, what is new out there? Are there any new medications that can help my condition, etc.? So I thought it would be quite timely, as we've been fortunate to have quite a few new medical research innovations, as well as drugs that have been approved more recently in the last couple of years. So it's always a good news for patients, but it'll be what I would want to concentrate on is also to explain to you how this might be useful for you and which group of patients, etc. And the next second half of my presentation, I would really like to boil down to the topics that probably concerns you more on a day-to-day basis, in terms of what kind of lifestyle consideration you might have, and how can you help yourself in managing this disease. So this is the list of actually the treatments that have come up and been approved within just the last 2 years. So as we know, myeloma is a condition which unfortunately as of today still remains incurable for the vast majority of our patients. But starting from probably 2012, 2014, there has been consistently new treatments that have received approval over the last 8 years, and it was particularly a good last 2 years for myeloma patients, as more new therapies have also come on board. So we start with CAR T-cell treatments, and I'll explain a little bit more about the CAR T-cells. I wouldn't want to dwell too much on the science, as it might be the time would not be allowing us to do that. But I will try and explain as much in simple terms as possible. The next group of treatments that have got approved, you might recognize the name daratumumab, which some of you might be on already as treatment, but the injection underneath the skin in the tummy that we often use, the subcutaneous formulation of this drug, also received approval within the last 2 years. And there is also another antibody that works very similar to the daratumumab antibody that also recently got approved in 2021. Now, there are antibodies which are basically proteins that target the proteins on the surface of myeloma cells on their own, but there are also antibodies that have now come up where the antibodies is attached to a payload, a toxin. So what this does is helps the antibody to bind to the protein on the surface of myeloma cells and then deliver this toxin into the myeloma cells so that they can be killed. And one of the first of those antibodies, called belantamab mafodotin, which is a very complex name probably to pronounce for anybody, but you can just call them as belamaf. That has also recently received approval within the last 2 years. And this is a drug that is still yet not approved by HSA, but it is soon hopefully going to be approved within the next 6 to 12 months in Singapore. Now, a drug with a completely different mechanism to the common drugs that you might have heard about and probably had, as many of you patients, the bortezomib group of drugs or lenalidomide group of drugs. This is an entirely new class of medicine that has been recently approved as well. And it works by affecting the waste disposal mechanism that a myeloma cell employs to survive. And hence, it's also looking like a very promising therapy, at least in patients who have had disease relapse after their conventional group of medicines. Now, many of you do like looking at videos. So as I always do, I have taken the liberty to get a video from Myeloma UK, which is a UK-based cancer charity, to explain immunotherapies and what they are, how they work. So could we have the video next, please?
Our immune system is made up of a network of cells and tissues that work together to protect us from germs and foreign particles. It recognizes our own cells, but tries to get rid of anything it doesn't recognize. Each of our cells carries a set of identity tags called antigens that are unique to us. Their role is to stop the immune system from attacking our own body. Anything or anyone else carries a different set of antigens, which the immune system removes before it can cause harm. Different types of white blood cells help make up the immune system. They work together to seek out and destroy anything that is foreign. Neutrophils and macrophages respond very quickly to the first signs of bacteria and viruses by detecting the chemical signals they produce. They remove them by engulfing and breaking them down in a process known as phagocytosis. Other white blood cells, called plasma cells, recognize foreign antigens and react by producing specialized proteins called antibodies. These antibodies lock onto the foreign antigen, flagging it up for destruction by other immune cells. Plasma cells also play an important role in building our immunological memory. This means they remember the same foreign antigen the next time it invades the body. They respond by producing large amounts of the same antibody quickly. Once the invading organism has been removed, chemical signals are released to dampen down the immune response. The immune system also tracks for changes in our body and removes any cells that are abnormal. Cancer cells are abnormal and may carry antigens that would normally be recognized as foreign. However, they also have other properties which stops them from being recognized and destroyed. As our understanding of the immune system has improved, new treatments are being developed which use the immune system to recognize and destroy the myeloma cells. This is known as immunotherapy. Some make use of man-made antibodies, called monoclonal antibodies, which recognize antigens unique to myeloma cells. Once flagged, other immune cells can quickly destroy them. Other monoclonal antibodies are made with toxins attached to them. When they lock onto the antigen, the toxin is released, killing the myeloma cell without needing to recruit other immune cells. Cancer vaccines are also being tested. This involves an injection of a small amount of man-made myeloma antigen, which allows the plasma cells to produce antibodies that specifically recognize and destroy the myeloma cells. Other treatments being developed include some which block the signals that normally dampen the immune response, as well as T-cell therapy and virotherapy, both of which are designed to recognize and destroy myeloma cells more effectively. Overall, immunotherapy shows great promise as a treatment for myeloma, offering long-term responses with few side effects.
Thank you. So that was just an illustration of how to understand how these therapies work. And I'll, this is on the public domain. So if you all want to have a look at the videos, not just for this one, but also to understand even the common medicines that you're taking, the Myeloma UK website on YouTube is available free of cost, and you can all download and watch the videos at your own time. This slide shows perhaps the complexity involved in CAR T-cell therapy, which might interest a lot of you. So what is CAR T-cells? So CAR T-cells, I mean, all the drugs that you've heard about for myeloma has thus far been acting as chemicals that are either directly killing the myeloma cells or helping other cells within the body to kill the myeloma cells. However, one of the key cells involved in such a recognition of cancer cell and destroying them are called T cells, which is a type of white blood cell. And here, this is the cell that is used as a cornerstone of therapy here. So this starts obviously with a patient. So instead of, you might have all heard about transplant or undergone transplant. With that, we collect the stem cells, but here we are collecting the immune T cells from the patient. The next step, the T cells that are collected are sent to a manufacturing site where they are genetically re-engineered and then made them and equipped them to be able to recognize the myeloma cell, which has perhaps cleverly gotten out of being recognized by our normal immune cells. But here, the T cells are kind of quote unquote taught how to re-recognize those cancer myeloma cells. And then not just equipping them to be able to recognize them, they are multiplied in huge numbers so that when the CAR T cells, now they are called as CAR T cells, they have been re-engineered and increased in numbers, and they're given back to this patient after a little bit of conditioning chemotherapy to suppress the immune system such that the incoming CAR T cells are given enough time to be circulating. They go and kill the myeloma cells in the patient. So this whole journey for the patient can take anywhere between 4 to 6 weeks. So this might sound as a complex table here, but I would like you to just concentrate on these three parts of the table. So here, there are these two approved CAR T cells. They've got very complex names, but you can perhaps remember them, ide-cel and cilta-cel. Ide-cel is one type of CAR T cell, cilta-cel is another approved CAR T cells. And here, this table column refers to patients who have just standard conventional treatment as they exist now. So in this particular trial, the ide-cel trial is 128 patients. Cilta-cel was trialed in this 97 patients and compared them to 95 patients who just received conventional treatment. As you can see here, it worked. This particular CAR T cell worked in nearly 3/4 of patients who had at least 3 prior myeloma treatments and who were, at the point of getting into the clinical trial, were still relapsing on their last line of treatment. And most of these patients had received much more than 3 lines of treatment actually when we read into the trial. Similarly, in cilta-cel, in this type of CAR T cell, nearly 100% of patients responded. But not only that, when we compared them to the conventional available treatments here, they were only effective in about 40% of patients. So it kind of gives you a flavor of how effective CAR T cells could be in this group of patients. However, as you could probably see from my previous picture, it's quite a complex kind of treatment landscape that is involved in CAR T cell therapy. Clearly, it needs a lot of complicated setup, not just for manufacturing, but also for the whole process. And there can often be delays in this whole journey from the collection process all the way to the patients receiving the cells back. So all those things need to be borne in mind. So in some patients, for example, the disease might be progressing so much, they may not have the luxury to wait for 6 weeks to get these CAR T cells being made and driven back into the patient. Another key consideration is whether the patient's fitness and the ability to tolerate such potentially toxic treatment and the complications that come out of it, whether they can be able to withstand that kind of toxicities. Not only that, more logistic considerations as well, because sometimes the technical aspects of involved in the manufacturing might mean that CAR T cells may not be manufactured, and this has been noted in US where after the CAR T cells have been approved, the manufacturing doesn't work as well in some patients. So, in a clinical trial, it's a much more controlled environment where things are done in a very certain way, whereas once it becomes approved, they are done in a slightly different way, such that not everything that happens in the clinical trial might be applicable in a real life situation. But the biggest consideration of all is perhaps CAR T cells are not being just employed in myeloma, that are used in many types of blood cancers, and in many other blood cancers, especially lymphomas. They are found to be very, very useful, where they not only suppress the disease, but perhaps in a good proportion of patients, they are almost like a cure. The cancer never comes back. However, to this day, still, in myeloma, the CAR T cells don't seem to have achieved that kind of remission where the disease is controlled on a very long-term basis. However, I would not put this ability of this particular therapy to achieve that. I think it is really a possibility that we might hit the target in myeloma where CAR T cell might be very effective in the near future. But those studies and those research is still ongoing at this present time. And of course, it's a more recent therapy, so long-term outcomes are still something that is still ongoing. Next, the second treatment that has received FDA approval is the so-called antibody drug conjugate, whereas as the picture, the video, as well as my earlier explanation mentioned. So this is a particular antigen target, and this is the myeloma cell, and the antibody comes, attaches to it, but not just that, it releases these toxins once it gets attached to the myeloma cell, and hence it helps to specifically destroy the myeloma cells. And again, just to concentrate on the efficacy of this particular medicine, here you see patients who have received at least 3 to 6 prior line of therapies, and in those group of patients, nearly 40% of patients are alive without the disease at the end of 6 months, and it is effective in nearly a third of these patients, whereas with conventional treatment, this is much less. And this is the other medicine that is, as of just earlier this month, got even the HSA approval, and potentially this is a drug that is accessible to patients in Singapore. So this drug works by a mechanism where the myeloma cell has learned and has the capability of pushing out cancer suppressor proteins from within the cell. And what this drug does is prevents that cancer suppressor protein from being pushed out of the cancer cell, and thereby helps the cancer to be kept under suppression for a long time. And this was approved based on this clinical trial where they compared, this is the new drug, selinexor, called Expovio in brand name, was combined with a Velcade drug, bortezomib, and steroid, and that was compared to other group of patients, as illustrated in this blue line, where they received only the Velcade and dexamethasone. And as you could see, patients who received only the Velcade and dexamethasone, on an average, nearly 50% of the patients relapsed when they reached the 9-month mark, whereas patients who received the new drug together with Velcade and Dex, they took an additional 5 months to relapse, for their myeloma to relapse. So it does look promising at this point, but as always, most of these therapies are quite prohibitively expensive. So probably the earliest and easiest way for our patients to get access, most of these therapies is via clinical trials. And many of you might have heard both, most of the private institutions, currently at least SGH and NUHS, have access to CAR-T trials. We have actively recruited in one of the CAR-T trials. Our first patients have gone through the CAR-T trial now, and it's a very poorly, progressing patient that we managed to treat the first in the CAR-T trial, and they're doing very well at this point. It's quite early days, but still we have, the ability to deliver CAR-T in Singapore. There are also other trials, the belamaf drug that I showed. We have clinical trials, as well as at the present time, the companies does offer compassionate access, meaning free drug supply for in particular group of patients. So it's with these kind of mechanisms that we are currently able to, access these novel medicines. And as always, all of the myeloma clinicians in Singapore have had a very keen interest, and Prof. Chung in particular has been able to drive the Asian Myeloma Network to be able to get more and more clinical trials for us. So next, I'll change track, and I'm conscious of the time. I don't want to overrun. Just a couple of lifestyle changes that I would like to emphasize that perhaps you would benefit from. So physical activity in cancer has long been a hotly discussed topic, and this is what we know as evidence from what does exercise do for cancer patients in general. So not specifically for myeloma, but for cancer in general. So we do have enough research to show that physical activity has a lot of positive impact in cancer patients. It actually, the strong evidence to support that, at least in some of the solid cancers, the magnitude of benefit that you get from exercise in some situations in some cancers is almost as much as chemotherapy. So we know how much of toxicities, and not to mention the cost that patients pay for for getting these medicines, but exercise can almost achieve as much of a magnitude in some situations. This is American Society of Sports Medicine that has come out with this particular guideline for cancer patients. So moderate intensity aerobic activity for 30 minutes for at least 3 times a week, as well as simple resistance training, can get you to get a good amount of benefit from the exercise itself. Now, it is not just physical activity gets you benefit from perhaps from your heart conditioning, etc. But there is a lot of research that shows that, contrary to or counterintuitive as it may sound, it helps very much to improve fatigue. So lots of our myeloma patients do report fatigue as a consequence of treatment. It is particularly useful to battle this fatigue out. Muscle strength and aerobic fitness obviously can be helped with exercise. And particularly patients who have been able to pursue this on a regular basis with a lot of will, their quality of life is much, much better compared to patients who do not have regular exercise. Further, the mental anxiety as well as sleep is particularly helped and improved with the ability of regular exercise, as well as self-esteem and some of the emotional aspects of the disease as well. But it's not as straightforward as we say. As you can imagine, myeloma patients are quite different to some of the other cancers. Lots of patients do have skeletal problems. They have backbone issues. They cannot move as much as they would want to. They might be in pain that can limit their exercise ability. They might have fractures and more. They might have impaired bone marrow function, which can make them anemic, and they may not have the energy simply to perform the exercises. So these are all factors that can potentially limit how myeloma patients may be able to adopt those exercises. However, with treatment, I think it's important to keep persisting. Do what you can at any given point in time. Doesn't matter how much or how long, but persist with it. And once your disease comes under control, which for the vast majority of patients it will, as the performance status improves, you would be able to do more. And then you could benefit from all the benefits that the exercise can give you. So what exercises specifically for myeloma? So these are based on the trials that have been done. It's simple home-based, so nothing fancy. You don't need to go to the gym or anything. Most of the patients might just be able to do simple walking, enough in brisk pace that is possible for any given patient to be able to achieve a slight increased heart rate. That is all that is required based on research. Of course, every patient is not made equally. You will have to consider and consult your physiotherapist, and has to be individualized to the patient. So patient who has had backbone fractures may be very different to how a patient who does not have bone disease and what they can do. And I do have younger patients who are even able to jog 2 and 5 kilometers. So that's a very different kind of approach to different patients. So that needs to be individualized. So the aim should be to build your strength so that you can keep walking, keep mobile, and keep active so that you can benefit from the exercise therapy. It has to be safe. Safety is absolutely crucial. What we don't want is for patients to get injured in the attempt to try and do the exercise, but it has to be feasible and also to be able to be performed on a regular basis. Next, body weight. So both cancer and non-cancer patients do struggle with this, but particularly in terms of myeloma, typically patients starting with a lot of bone disease, they do develop fractures, they lose their capacity to be able to exercise, muscles get deconditioned, and then they start putting on weight. And the treatment doesn't help sometimes. There's a lot of steroids used in myeloma, all the way from induction therapy to thereafter. But as physicians, there is a lot of recognition that has gone on over the last 10 years that steroids have their role in myeloma. But once the myeloma disease is controlled, once patients are in reasonably good remission, you would all find that most of us clinicians start reducing steroids. And then you find that many of the problems actually are caused by the steroids themselves. And one of them is weight gain. So it's important to have the steroid reduction as an ongoing consideration for all patients. Next big thing I would like to stress, and many patients do complain of, in fact, many of them only mention this as to me during the follow-ups. Sleep disturbances affect subconsciously a lot of things that perhaps we don't realize. Sleep deprivation leads to increased risk of infections, increased cardiovascular diseases, diabetes, even cognitive and memory decline. It causes a lot of metabolic changes within the body. It increases the cholesterol-related problems, as well as, not to mention, the mood and emotional sides of it, as well as increasing the body weight when you don't sleep properly. What does cause sleep deprivation in myeloma? Bone pain and being in some kind of discomfort obviously doesn't help. And steroids again is another problem here. Affective disorders, perhaps you're emotionally disturbed because of the diagnosis or what phase of disease you're at. Also some treatment, other related side effects, for example, neuropathy that can be precipitated by some of the drugs that we use in myeloma, unfortunately gets worse during the nighttime, and that disturbs sleep as well. And kidney failure is also a risk factor for sleep deprivation. So how can things be helped here? So it's important to have a good sleep hygiene. As much as you're tired or fatigued, if you can limit the daytime naps to as minimum as possible, and then kind of exercise towards the evening so that it kind of tires your body out, so that by 8, 9 o'clock, whatever time your regular time bedtime is, you can get to a reasonably good time as your body is tired from the lack of sleep during the day and the exercise. Maintaining a consistent sleep schedule can be quite helpful. Rather than sleeping at 6 on one day and 10, if you keep a consistent time, your body clock kind of adapts to that, and that can help with induction of sleep. Avoiding simple tips like avoiding coffee, alcohol just before bedtime can be of huge help. Noise and light reduction in the bedroom where you sleep, and not to have mobile phones by the bedside also helps. And as I mentioned, withdrawing steroids is often helpful. And these are other, simple things. If you're into massage therapy or, relaxation, gentle music can also help. Those of you who are my patients know my strong dislike for sleep-inducing medicines. They might have their role for a very short time, but generally, they are addictive, and the longer run, they don't help at all. So to wrap up, it's quite fortunate that we still have a lot of research going on in myeloma, and we still have newer and newer medicines coming up. Hopefully, with time, we can see all this materialize. At the moment, it's via clinical trials, but at least we can hope that many of our patients in Singapore can get their access to this medicine. There is a lot of promising efficacy in many of these new medicines, and one day we are still hoping that we'll be able to get treatments like CAR T cells early on, soon after your diagnosis, such that the CAR T cells will keep the myeloma under check for a very, very long time, so that you don't have to be on medicines on a regular basis every day. And some of the other tips that could perhaps help you to keep your daily routine with exercise and sleep, to be able to help yourself. I think there's a whole talk on nutrition and diet, so I'm keen to listen to that as well. Thank you.